we could just start making our way back to our seats, we'll start on time for the next session.
Okay, guys, take your seats. Got a really exciting next session. Just before we start, I'd just like to draw your attention to these flyers, the table at the back right, which Jill Salter from AbbVie was manning. This is to introduce you to the idea of the Hepatitis C Summit. Now, the Hepatitis C Summit is being held in Auckland on the 27th of July, Friday the 27th of July. And the purpose of this summit is to bring together everyone involved in the management of hepatitis C, including representatives of the affected community, to come together to work out what we need to formulate a national plan, which is what I mentioned, what we need to go forward if we're going to achieve the WHO elimination targets by 2030. So this summit is open to anyone with a specific interest in managing hepatitis C. If you pick up a flyer, there are instructions on how you can register. It should be an exciting day, running from 10 till 3. David Clark, the Minister of Health, will speak at the day, and we've also got overseas speakers, Homi Razavi from Colorado and Greg Dorr from Sydney. So for all of you who are interested in looking or registering for this, if you can pick up a flyer before the end of the day on the back station. Okay, now I'm just here really to introduce the first speaker, and that's Sarah Middleton. And the reason I'm introducing Sarah is a study coordinator who works for the ADHB, and Sarah's been given the task of drawing together the results from people whom we've treated with Viekirapac. As you're aware, as I mentioned, Viekirapac was funded from the 1st of July 2016, and since that time, close to 3,000 people have been treated with Viekirapac. And it was a concerted effort to improve access to treatment that we really simplified access. And by simplifying access, I meant to get primary care involved. The applications were very simple, so everyone could access treatment. And unfortunately, part of the only downside of that is that we don't have much data on outcome of treatment. In fact, we don't know the percentage of people who have been cured, who have been treated to date in Viekirapac. So we put forward a proposal based very much on the Australian proposal, which they have set up by their Department of Health and Ageing, to try and collect all the data for everyone who's been treated by Viekirapac, to find out the cure rates in New Zealand, to find out how we're doing in primary care, really to feed back to you how well you're doing. And for that, we need to collect a bit of data, what we call baseline data, which was never collected in terms of the Pharmac data collection. And we have to thank Mina from Pharmac, who's been extremely helpful in supplying the identifiers of everyone who's been treated with Viekirapac. And I'll hand over to Sarah Middleton, who's going to explain to you how we plan to collect the data on your patients who've been treated with Viekirapac. Sarah.
So the database is called REACH-C, and that stands for Real World Efficacy of Antiviral Therapy in Chronic Hep C in New Zealand. And that real world efficacy is that the stats we currently use are mostly based on clinical trials, and they don't truly represent how we're treating and where we're treating in New Zealand. We've got here the stats showing the prescription of Viekirapac over time, which Pharmac has funded. And you can see there, July 2016 was when DAAs became funded, and October is when they were allowed to be prescribed by GPs as well. And that simplified process allowed prescription to move in, reduce the burden in secondary care and move into places like GPs, community centres, prisons, which really helped treatment of marginalised populations who were not happy coming to secondary care. So this is the Viekirapac distribution request form by Pharmac. So this they removed the requirement for special authority and simplified the process. But that leaves these questions: who are we treating, what are we using, and how are we going? So the big missing questions are the SVR overall results in primary and secondary care, how many virological failures over the whole of New Zealand. So why do we need this treatment data? So New Zealand has the largest real-world experience of Vicaripac, including community prescribing. And the results of this database will inform the Hep C infected community and GPs on the safety and efficacy of Vicaripac. It will inform Pharmac on the rate of treatment failure to determine the need for retreatment regimen, and it will pave the way for future pan-genotypic DAAs. Where are we up to? So database manager funding has been secured at ADHB. In May, we acquired ethics approval and institutional approval for gathering that national data and holding it at ADHB. And we have begun retrospective data collection of the Vicaripac from 2016 up till present. So Pharmac kindly provided the distribution data up till 4th of June 2018, which is around 3,000 patients worth of data. And based on that, I've started doing the REACH-C collection just in the Auckland region. So we've got ADHB, counties Manukau and Waitemata have kindly pruned down the database, had a go at using it. So thank you to Lucy Mills, Christine Hayes and Bridget Fair, who all contributed to what the final database looks like by being guinea pigs. And then moving after that will be the prospective data collection of Vicaripac and any other DAAs. So the retrospective data collection, how are we doing it? It's a very minimal database to cut down on workload and time, but still achieving the endpoints that we want. Database manager to pre-populate most of the baseline and treatment data using that Pharmac distribution data and National Health Index. Primary and secondary care nurses to provide other baseline data, SVR 12 results, and for patients who stopped or failed treatment, the missed doses and reason for termination. So it will be held as an Excel file. So here is the baseline data we'll collect. So you've got here the Pharmac order date, patient NHI, date of birth, the prescribing doctor and treatment centre, the type of treatment centre, DHB, gender, ethnicity, cirrhosis, yes or no, genotype, any previous Hep C treatment, and in the case of DAAs that's specified. And then the planned treatment, the duration, and the source of funding. So it looks quite big, but actually most of the data is coming from that Pharmac data, and what I've circled there is probably what I'll be requesting from the nurses. The SVR12 result, cure, failure, unknown, lost follow-up, unknown, death. So by having these kind of filters, it will be easy to complete and easy to review. Treatment failure data, did they miss doses? Why did they miss doses? And any specification. So why do we need you? What can you help with? So database manager at Auckland City Hospital will provide on-site remote data entry support, quarterly teleconferences, and support over the phone. That minimal database and most of it pre-populated from different areas is to simplify it, and the simple methods for data submission as well. So that Excel spreadsheet is one way that you can complete it and submit it that way, or via hard copy sheets or another option. And the data sharing, so regular reports will be sent out and anonymised data free on request to all users. And the precedent for REACH-C was set up in Australia, so the Pharmaceutical Benefits Scheme also had really minimal data collection for all their DAAs, and so the Department of Health and Ageing funded the Kirby Institute and University of New South Wales to start this REACH-C database from March 2016 when their DAAs became funded, and the data is used towards the Australian Hep C elimination strategy. So it tracks the safety and efficacy of DAAs and reports trends in treatment uptake. They collect their data in a slightly different way, as that they have satellite sites trying to be representative of the whole of the way that Hep C is treated in Australia. So they have it at primary care, secondary care, needle exchanges, but they have a set number of sites, and they test a few more things to do with baseline factors to really look at treatment uptake in different populations. And then they track the treatment details and the outcomes as well. And that data is used towards these nice newsletters that Kirby Institute bring out, which I do recommend reading, monitoring Hep C treatment uptake in Australia. And here's the contribution that this REACH-C data provides for that. So you've got what are the cure rates by genotype. You've got what are the cure rates based on those baseline factors, so HIV status, cirrhosis, prior Hep C treatment, injecting drug use, and opioid substitution therapy. And our minimal database really has cut out a lot of those baseline factors, which Australia was able to collect. And this is some of the overall Hep C monitoring data. So you've got treatment uptake by numbers and by different regimens, and where it's being prescribed from. So acknowledgements, I'd like to thank Kirby Institute University of New South Wales for their involvement in the setup of the REACH-C database, and also my manager at Liver Research Unit. Yep.
Any questions to Sarah about that database work? I think it is important. You can't, as clinicians, I don't think we think about data enough. I don't think you can cure diseases without data to tell us how we're going, where we're going, what have we done, what areas have we not done. So I think data is incredibly important. So, yeah.
We wanted to set it up. It had to be done at one site. It couldn't be owned by an independent source. But the data is not owned by anyone. The data is for all of you who contribute data. And we're going to have it opened up to anybody to report the data. I think, and we've discussed this with some of my colleagues around the country, I think we need to have a steering committee. I won't be on that, but there'll be one or two colleagues from around the country who will listen to, if somebody wants to publish national results or present national results, they're free to do so, but they could contact the steering committee to make sure that it hasn't already been done. And then all the data will be supplied to whoever that person may be. So we don't want to restrict use of the data. We think it's important data because, as Sarah said, it is the biggest real-world experience with Bicara PAC, and it's the biggest community prescribing in the world. So I think it's important that this data is presented, and I encourage some of you to think about how you would look at this data.
Okay, so coming up next we have Annie Zeng, who's going to talk to us about hepatitis diagnosis and management in the prison setting. So Annie has worked as a primary health nurse with the Department of Corrections since 2008. She is currently working at expert level and completing a Master of Nursing at Massey. She's been growing and expanding her hepatitis C portfolio since starting the role and works closely with Dr. Jeff Wong and hepatitis C nurse at Hutt Hospital Ying to run the clinics with Rumitaka Prison. So we look forward to hearing your experience. Come on up.
I'm shaking at the moment. Sorry, supposedly organized as my co-presenter, Ying, but she's enjoying her lovely holiday in Singapore. Leave me here alone and shaking. Yeah, all right. Anyway, and thank you give me the opportunity to actually present it here. So let's start. The objectives really, the reason here is I'd like you guys to get a little bit insight that how we work at prison to managing hepatitis, and maybe we can see what we can do in future to improve. I like this statement. That's all, thank God, for my studies for the last couple of years. That's a statement from the WHO. Prison health is public health. And that's really, I put it up there, just really try to show the message that prison health is very important. So in New Zealand, we got 14 male prisons and 3 female prisons. We under 4 different regions. I guess maybe similar to DHB, but that's how we work at corrections. On this slide, there's a couple of figures I'd like you to pay attention to. So, is it the light? Oh, sorry. Okay. So, that's movement, that including courts movement and medical movements, like go to hospitals, anything included. That's about 39,200. And then we got community-based, offenders. Sorry, the light is gone. Oh, yeah, here. It's about 29,000. Community-based, and for the health care consultation by healthcare staff, each year is over 100,000. I'm sure there's a lot more than that. My colleagues under there will know that. By the way, that's year 2016 data in August. Like I'll just say, give you an example, in Rumataka prison itself, in the afternoon duty, we hand out about between, depends on the days, between 200 to 300 medication to people. Yeah, 200 people actually. So another thing I didn't mention that data on that sheet is average staying for prisoners or inmates, what you call it, is about 56 days. So what that means, I want to emphasize, is that most of the time, the people we work with, or our population actually is in the community with us. So that's why prison health is very important. There's a Rumataka prison where I work. You can see it's quite a large prison. So have about 51 is in Upper Hutt. And one of the largest prisons in New Zealand, we can usually take to just over 1,200 inmates. At the moment, I think they are thinking about expanding, add more beds. We carry from minimum to maximum security. We have kind of our feature units is called Intervention Support Unit. What was the old name? At Risk Unit, yes. This carries people like who need support, when they're at risk, they have mental issues and self-harm. Risk to themselves. And we have a self-care. Self-care is like a minimum security. And those people there, they have like a boarding house. They pay rent. They go out work, actually. So while in prison, we still have people come to our community. And another thing was established, I think it was the year 2010, was high dependency unit. That's people that is a service created for like a rest home and hospital care. Okay, so that's a typical high, medium security units. That's inside the wing, we're called. During the day, those people in this unit, they can spend about 1 hour, they call it wing time. And another hour is a yard time, a very small yard, and that's it. And the rest of the hours they'll be locked. And that's low to medium security unit. That's outside, and they but lucky they can be unlocked from 8 o'clock to about 11:30, locked up for lunch, and then unlocked again from probably 1:30 to 4:30. That's inside the cell. Lots of them are actually at the moment is double bunked. You can see the space, very small space. Have to share the toilet. They actually create a kind of lots of problems at the moment. What I try to say this could be another topic for all day, that how the prison environment actually affect the health and affect the attitude, towards health, to make them even more disadvantaged for their health status. But that's another topic, it's not today. So for minimum security, we need a 1 officer escort, and when they go out, and for 2 or even when they're inside, so internal transfer as well. So low to medium security is 2 officers escorts, and then you got maximum security, there will be handcuffed 3 officers. So short of staffing will be even more crucial in our setting. And all I try to emphasize is overcrowded and create more problems. Hepatitis B. What we do with hepatitis B, like our colleagues mentioned about before, we do screening. When they come in, a screening program, screening is offered to everybody. Walk through the door, hepatitis, HIV included. We have other screening as well. People don't have immunity. We actually offer hepatitis B vaccine, which is for free for them. And if they need treatment, and we provide treatment. And the monitoring as well. And referral, we'll have a close link working with the hepatitis foundations. Referral to them, so kind of promote the continuity care. So when they get out, they can be followed up. And of course, if they severe fibrosis and cirrhosis, we'll refer to a specialist. That's the only data I collected, because I have to go through my orders for the vaccine. Because I haven't got time at my assignments due next week, sorry. Yeah, we actually did 122 vaccines. That's from, I forgot, from year to last year until June this year. So I thought it was quite impressive. That's why I put it there. No. Hepatitis C, that's what I do. I have hepatitis portfolio. So all it started was that before the pilot started, actually, lucky picking on that portfolio, I learned heaps. So that's the past. Before we start the clinic in Rumataka, our patients have to go to make an appointment to go to see Dr. Wong in the heart. And then the appointment usually make it 2 or 3 times, 2 or 3 months ahead. But if by accident the prisoner knows they're going to have an appointment, that appointment has to be changed because there's a security risk. If they go out, they can organize drug drop off and things like that. Usually you attend 2 or 3 guards, depends on the security. 1 prisoner a day, they can go because there's some other emergencies as well they need to go. Usually, other presenters said, the hepatitis chronic, usually probably, I won't say bottom of the list, but it's not priority because it's not emergency. So when we have a treatment, we'll be quite limited to follow-ups, phone tagging. Every time Ying will try to ring, that wasn't me. She will speak to any nurses, and then the nurses pass message on to other nurse. So sometimes messages get missed, the blood tests get missed. And then since the pilot, we actually set up clinic. Me and Ying run the clinic every month, once a month. Now it's quite well established. So I can get some trust from the doctors. I ask all the nurses and doctors to give me notification by email or task when they see anybody is positive, or just positive antibodies from the testing or screening we've done, and then I start the follow up from that point. And we do face-to-face consultations. So when Ying's not there, I'll see them on the weekend, or when I have spare time, I'll see them to follow up. Fiber scan, lovely nurse Lanier. I usually ring her up or email her to try to want to get a 1 or 2 ready for need for fiber scan. They say, "Oh, can we have an appointment?" And then usually about 6-8 weeks time. And then sometimes I'm worried, oh my God, how many I'm going to get this time? Most of the time, been doing quite well. We usually have 6 to 7 booked. And then bound to be every single time there'll be 1 not released. But for the last, we start about every year about 4 or 5 clinics. So we're doing actually in that aspect doing really well. I do all the pre-works for the doctors, get them prepared. I do all the follow-ups, the monitoring through the treatment, or just in general monitoring when they're not on treatment. So there are some barriers and challenges that we do face on a daily basis. I put everything under the access, so as barriers, so basically anything can reduce the access for them to access to help. So one big thing is security. Maintain security is a big challenge. So if anybody or apart from my colleagues, red code. One person in the red code, nobody moves. Doesn't matter where you are. If you're outside, you stay there. We got a large area, all have electronic gate. So if you're at the gate, you stay there, wherever you are. So this can be a challenge if I have an incident, and then the unit's not happy to send the prisoners up. So the blood test have to be rescheduled, or even the appointment have to be rescheduled. Lots of other things. I got too many things in my head at the moment. Anyway, and short of staff is actually quite a big challenge. As you say, the officer will have to have adequate officers to escort them. Doesn't matter if it's internal or external. And highly transient. Our population will get a weekly transfer from prison to prison. And then also releases. Yeah, sometimes they go to court and they get released, a spontaneous release, and then they're just gone. And then because the nature of the population, sometimes even though they're on treatment, they can't, I don't know what's the reason for them not to come back to pick up their medication, they're just gone. So that's quite a big challenge. So it's engagement with health. So the blood test, the screening is under voluntary base, so we can't really force them unless they agree. So we can always encourage them. So how we can capture that's very, very important. So I'll just say being incarceration, I always say to them that could be you're taking as a positive thing. Because our population, big problem is that they don't actually engage in health. Lots of them don't even have GPs. So for them to come incarceration give us a very little window opportunity to actually catch their attention. So like, oh, I might do something for my health. So we need to actually treat that as a very treasure point. And also stigma is a big problem. Fears from others, lots of them are scared to come to prison. When come to health to do blood tests, if you say hepatitis, everybody's scared. In fact, lots of times I offer them, I said, do you want to take the brochure home to have a read? Oh, no, too scared. Because we do have people. And then the other day, just last week, I have to tell bad news to one of the prisoners. He got just newly hepatitis, and he went back. He'd been honest to his cellmate, his double bunked, and say, oh, I just got told I got hepatitis. Next minute, I got rain from the unit. He got kicked out. So he's not double bunk. He has to go to another unit because his soulmate doesn't want him anymore. So that's, lack of a stigma is quite bad. And other things I put in others, health literacy. There's poor health literacy have a huge impact. Our big population, like 1 in 5, can't read, and we've got people high prevalence in mental health, head injury. Had research data. There's data on the correction website. About 75% people have head injury, so that will affect their comprehension, I guess. Another thing is everything treatable. If they can sell, they sell everything. So some meds, it looks very fancy. They don't really know what it is, but they just want to have it because it's a drug. That can be quite, pose a risk for poor compliance. Some they offer you $5 or $10 or whatever, and you give it. So let's see. Another thing is that our reinfection risk at prison is quite high, because it's because the needles or the tattoo. Prison tattoo is really popular, and then. Because the contraband environment, they kind of, if you tattoo in prison, obviously share needles. So I actually have during this years people infected by tattooing in prison, and also it's risky behaviour. We should be drug free, but occasionally something happens, and then the risky behaviour when they're released. They start on drug binge and then come back with a positive result again. Another thing to me is like a lack of family support. When they go there, they're quite isolated, so you find like a support, and that's actually reduced the engagement. And sometimes put them in the, I would say, mental health, they're depressed, they come to a point I don't really care. But there are lots of advantages. So it's easy to calculate implementing policy support practice. So the hepatitis screening, so it's easily implemented. So we did a huge project with Hepatitis Foundation, like the HEPC pilot. Took a little bit of organisation, but we've done it. So that's very good. It's contained in a stable environment, like I said before. Alcohol and drug free, and the interferon phase is no contraceptive concerns. It's easier to access for treatment and follow-ups. So before that, like I mentioned before, you one appointment once a month to see Dr. Wong. So since we set up clinics under Dr. Wong, usually I'll keep it to 4 to 5 treatment, no more than 5 because of workload in the interferon phase. Usually we have our 4 to 5 stable patient all the time, at any time. And then they don't have to go out to see Dr. Wong all the time now. They just come to see us. So that's a huge reduction in cost. And also the blood tests obviously get followed up. Easy to manage, because I've been there for a while, and then like I said, report is very important to improve the compliance. So if they trust you, they believe you, they want to do things with you. And consistency approach. So also being there full time, so it's easy to engage with the GPs and the specialists. So if you have anything side effects, you knock on the GP's door, can we have this? But if I say Dr. Wong said, can we have this? It's quite hard, quite easy. Peer support. So the inmates actually they're quite good. I had a patient that's during the interferon treatment, he was suffering really, really bad side effects, and he had actually severe head injury. Some stage he just said, no, I can't cope anymore. He's actually cellmate. not cellmate, in the same unit. He been through triple therapy. That's one of the inmate. He gave him lots of support, and that particular prisoner actually completed interferon treatment. So that's really positive. So I'll just put advantages: increased diagnosis, compliance, and successful rates. You talk about the GP prescribing Vicaripac. From year 2016 October, become a GP prescription, to middle of year 2017, I still was relying on Dr. Wong. None of our GP had any prescription, so I developed that flow chart. That's my product. Took me a while, but anyway, and I try to preserve our precious GP time. So all of those, I said, you only need to do that purple area. If you get a positive result, send me a task or send me an email. I'll follow up, even just antibody positive. And I'll do all other areas or other colors is me. And then when I get them ready, they need a prescription, genotype 1A, 1B, and I will look at the drug interactions, anything that I need to put in plan, and I'll do that. I get them ready, everything cleared. If they need to stop atorvastatin, and I'll tell the GP, either discuss them to stop beforehand. It's for that 3 months, and resume later on. But anyway, just get them all ready, then I book them to see the doctor, get a prescription. Once they get prescription, back to my hand again. So I do other referrals as well. And that has been working really well. Like I said, we usually have like 4 or 5 people on the treatment at any time at the moment. I just got a couple of quick case studies. Yeah, 48-year-old New Zealand European. He's a genotype 1A, mild fibrosis. And he's only just had, 20 years out. 20 years of being a Hep C positive, history of IV drug use, no history of alcohol use, which is positive, and he's currently on Suboxone for opiates replacement. And that's Sam, I call him Sam. He started Vicaripac, and then week 2, he started complaining, have vomiting and diarrhea. And then I'll get, he's kind of like quite vulnerable mentally as well, but no such a diagnosis or anything. And then sometimes I just walk into the door and the nurse said, Sam said he's going to stop treatment. He's not going to take any more because of side effects. So I have to have an emergency appointment, see him, give him lots of reassurance, and talk about, get our GP to check some PRN for his nausea, loperamide for his diarrhea, and then seems to be settled. And then he will come up with something else. Just about every week I walk in and I say, he's going to stop treatment. Anyway, but he did show some symptoms. So I think it was genuine. He had a 4 kg of weight loss, but he doesn't want to take any extra milk or something. So at prison, our menu is national standard. So you get extra food, it's actually really, really hard. And he refused to have extra milk or something. So he said, I said, what about something, vitamin or something? So ensure his have good health. So he agreed with that. So, and then halfway through the treatment, and he's still saying he's still suffering, couldn't cope. So I talked to Dr. Wong. So we actually kind of stopped his ribavirin. He was just on Vicaripac. So it's not going to compromise too much about his result, about reduce his successful rates about 2%. So we thought maybe better to get him finish the whole treatment, and rather than just halfway through he's going to stop. So he is complete the treatment now. I was just waiting for the 3 months checkup. Fingers crossed, and he's actually liver function tested. It's not requirement, but I did test it. Came back as improvement. normal at the moment, so fingers crossed. Yeah. Oh, okay. The case study 2 is a 48-year-old Maori. He's got genotype 1B. He's mild fibrosis as well. And he only have a 3 years a history of IV use, and obviously, like, I don't know, I won't say obvious, but he's quite impulsive. He's got lots of mental health problems. He's got ADHD. He's got says bipolar, and he was on massive dose of quetiapine along with other drugs. So the preparation for John was quite complicated. I started seeing him since he came back, like from last year 2016, because he knows. He said, "I want to get treatment." So I talked to him again. I see him like it used to be monthly. I said, quetiapine is a big issue. You can't have that big dose because otherwise you can't have the treatment. So took a while. We finally come to conclusion. He's under forensics as well, so he's definitely got mental issues. Come to in January, and we had draw a plan. So I said, what about you just slowly reducing your quetiapine, and then once you're ready, then I can book you to see the doctor, start your Vakerapac. So, but everything have to be notified the forensics as well, because they do the follow-ups for his mental states. He agreed. So but he's really determined. So he reduced his fast track his quetiapine reduce and things like that. He was ready. It was prescribed early April, and he was so excited. Got on. One week. After 1 week, he started complaining. Same side effects as the other one. I have a little query. I don't know whether people not on ribavirin, what's the chance for get diarrhea, vomiting. But I think those two were talking, but never mind. I have to treat them. I treat him like he has. Anyway, can't. And then I thought, oh, well, he's off Lexinase as well. That's kind of an interaction, even though just nasal spray. So for the safety, I actually took the GP, stopped that, gave him a cetirizine for his high fever, and that's no interaction according to the Liverpool interaction chart. So he's doing 1 week through. So I can't handle this anymore. I went to work. I got reported, and then I went to his unit straight away. He actually did show a huge deterioration in mental health. He looks, I could tell he's not well. And the trigger was he was double bunked. He moved the unit to the other unit and start double bunking with somebody else. So he never actually was in the double bunk. I think that probably triggered him. And he said, I haven't been asleep for a long time because of quetiapine. He got no quetiapine. And then, I don't know, I can't cope. Now I have to get up 3 o'clock in the morning, go to the toilet, and my cellmate suffer and things like this. And he put it in a nice way. So anyway, I talked to my manager because we can't just send advice saying you can't double bunk because of the shortage of bed. So I talked to my manager, and then I went, agreed to support him. I went to talk to his manager, the unit manager, and presented the situation, his case, and see whether considering give him a single bunk. And he used to be a wing worker as well, so do some cleaning in the wing, which is he loves it, something to occupy him. So I thought maybe something we can put in place, get him to start something like that. Because in the unit, since new unit, everything takes time. But everything put in place, and also I contact a forensic doctor, psychiatrist urgently. I said, can we get some verbal order for him to get him sleeping on track? And he actually said when he was on olanzapine, it worked really well. So I checked it on the drug interaction thing again, and then he started on olanzapine. Big improvement after a few days. And I said, I'll book to see you on the weekend, which is just 5 days. I said, I'll see how it goes. And in the meantime, I said, maybe just only 1 week start, we withhold you Vakerapac. He was not going to take it anyway. So I reviewed him on the weekend. Improvement. He said, I need my olanzapine up a little bit more. He also got urgent review with the forensics the week just on Monday. I saw him on Saturday, and he got his olanzapine increased. I booked him. I said, I'll see you the next weekend. And then the next weekend was a remarkable improvement. I said, when do you think you can start? He's very keen to start. I said, maybe I'll get everything in place, get your side effects, like albenzatrol, loperamide in place, just in case. And then also forensic willing to give him some olanzapine PRN as well to help him to settle. And that everything, I think it's just huge reassurance for him. And he started again. That was, I was talking about that before. Yeah. So he started his treatment, and now he's still, he's halfway through. He's halfway through his treatment. I've been I've been seeing him weekly. So tomorrow, Saturday, yeah, I'll see him tomorrow. So he's happy. Now he's not complaining any side effects. In fact, he's not taking any of the PRNs. So he's happy. So what's the future for us? To me, I still think raise awareness, testing and treatment, educate. Educate is, I think, like a part of a promotion. Not just educate patients. We've got educate the staff, educate the whole community or society to get rid of the stigma or minimize it. And to me, another thing is that work together within the justice system and with prisons, probations, courts is actually very important. So you can promote continuity care. Because, like I said before, the thing is when they get released, it's really hard to get hold of them. And now maybe I'm thinking creative of being have a community nurse employed in corrections, so working kind of a cover every area. Any volunteers? Can working on that, and just raise awareness really. So my key point today. Spread the words out, but not the disease. Hopefully we can stop disease in the prison setting. And that's me.
That was a great overview of your work and that experience. I've got one question to get the ball rolling. We know that these people get moved around a lot between prisons at very short notice.
Yes.
Do you have links and networks with your prison nurses in other prisons where you can forward on your notes for a start, so your clinic notes on what work you've already done, and if someone was actually on treatment, whether you can get their Vicarea pack moved with them to the next prison or couriered along after them in as short days as possible?
Yeah. I'm using my way. Like I said, I classify everybody. So when I see they're positive, I put it on. We use MedTech, by the way. So I put it under classification. What's genotype they've got, kind of like FibroScan status when they get the data, and then if they start waiting for Vicarea pack or waiting for FibroScan, I put a Q's in there. And then if they start Vicarea pack, I put a starting date, finishing date. And then obviously when we do reviews and like clinical notes, I say week 1 into treatment or week 4 into treatment and things like that. So hopefully, and we do have a system to record forms we do when they transfer. It's a transfer form. We do on everybody, not just if the patient got no medication, it's no medication, nothing. So that's also another way to cover, and also handover. It's just general. It's not every prison. I think we got hepatitis, not say designated, a portfolio holder. So sometimes, like I say, just kind of a handover in general to run up courtesy and say, look, you got somebody come in, because I certainly got phone calls, come in with a Vicarea pack. I had people come in with on Hawani, and then the medication is delivered. Go with them. Yeah.
And to the nurses in the room who work in the prisons, does that work? or do you think that there's systems and processes that could be put in place to improve that?
It does. It's the sudden releases from court that are the big problem.
Yes.
Yes, generally we know when they're transferring, and our pharmacy issues the whole 12 weeks or whatever at the one time so that they can continue treatment.
I had one guy transfer to me. I did miss, and he was like, I don't know, 4 weeks or something, the Vicare pack, and Rubivarin was missing. Got his Vicare pack, and then I think I was contacted as a mid-central nurse. Was it? Hi, we were talking on the phone. Yes. Or chase that and say, oh, he's got everything issued. We can't do this. I said, can't be, because he's not here. He's got some of that, but I haven't got the Rubivarin. So I rang the prison, and they said, no, everything's gone. And then I said, no. I said, oh, and then I ran back the third time. I was lucky. I was phone tagging with you that day, am I? That actually the prison nurse find a bottle of Rubivarin opened, hidden in the shelf somewhere. And then, but I got them transferred, so it continued. There was not issue. He actually cleared. It's all good.
And in the far side of the room there?
I normally put a non-transferability in IOM, so the prisoner will stay in our site.
That's I did this for interferon treatment because it's kind of quite difficult to transfer people while they're on interferon. But with Vicare pack, I think I didn't think it's a huge risk as long as we put everything in place. So people, if they actually have family support in up north, I feel like I should not hold them in Rumataka. So for that, or somebody they actually go on for programs to get like a DTU program or something like that. So then it's another reason you should not hold them. I had a patient like that, and then they just get and they need transferred. But interferon, I put a non-transferable for them for like, depends on if it's 24 weeks, I put another 3 months on top, not to be transferred. If it's like 48 weeks, I put another 3 months or 6 months, I can't remember in there. Too long now.
Because it's the problem with the Vicare pack being transferred from one pharmacy to another. That's why we put that in place. So custodial staff would ask me what's the reason for non-transferability, and I'll just say they're on treatment, and they'll hold them for just like if you have started midway, so they'll just finish treatment, and then that's the time they'll be transferred. That is how it works on our site.
Yeah. Our pharmacy is quite good. Usually I give them a notice, say, look, somebody's going to be transferred. Can I get the whole treatment and then get transferred? So that's all. Yeah.
Any other comments from any of the other prison nurses here?
Yeah, from our pharmacy, we normally get the whole treatment packs regardless. So we just, the little bottles, just put it into their medication file. Once they get transferred, the whole thing goes with them. We've had a few issues from other prisons, including ourselves, where they may have left the box behind, which does happen, but we normally get it there within the next 24 hours anyway. The only issues that we do have is the immediate release from courts, or they just don't come back. They get released from our prison after court, and they just never come back the next day to pick up their medications. Those are our biggest issue is a court release. Once they get released from court directly.
Any ideas about strategy?
We can't do anything because we can't give them the medication to take to court because we don't know if they're going to get released or not because we're only remand. They have to come back the next day and pick it up. But if they come back to us that night and get released, then we give them the supplies. Yeah, so the court release, unfortunately, because they're outside of prison, we can't do anything for them.
Sorry. I just with maybe you can consider. I ask our pharmacy to blister pack Rubivarin, so that's easy and hard to miss rather than in the bottle because you get people. I get 4 or 5 people on same treatment and you Rubivarin in the bottle if they using other people's and then we mismatch. So get them blister pack Rubivarin and with Vicare pack, this daily pack. That's not a problem. And then talk about release. Yes, I have a couple of cases. One just instant release. He just gone. But saying this to me, like I say, I talk about raise their awareness and raise they need to learn, or they need to actually know how important it is to actually comply the treatment. He went down south, went to somewhere program, but he was released in the community base. He actually went there, obviously lied to the to the nurse to say he never had a treatment, which is I actually got a whole month's supply there with me. He already started treatment because he think he can get it again, doesn't matter, and he got it, which is good. That's one, and the other one was like this kind of related to the risky behaviour. He actually said, he was gone straight away from court. Oh no, he wasn't. He actually said, I'm going to court on that day. I might be released. So I was talking to him, get him prepared. I said, you need what to do. You need to follow up with this and see this and blah blah blah. And then on the day, saw him. I said, in the RO, receiving office where they get released. He actually came back. I was really grateful. I said, look, I get you organised. I get the officer to drop you at the pharmacy before you catch the train, get your last month of a care pack. And he was really grateful. He looks very sensible. So I gave it to him. You know what? He came back within a week, didn't have a care pack with him, and didn't take it. One medication after he gone. So I saw him. I said, what you going to do? He said, I went out with my sister. So he went out on a drug binge straight away. So at the moment, I still follow him up. I say to him, I said, look, when you actually come back next time, if you're going to stay for 6 months, let me know straight away. I'll get you on treatment.
Excuse me.
Thank you.
I just
Sorry,
want just
one
a
more question.
quick question. Is it possible for the prisons, when we get the patients released into primary healthcare, to courier out the rest of their medicines?
Oh, definitely.
You'd
It's like that's actually our general rule. So even just normal medication, if they're long term, we give them at least 1 week supply. Now we actually improve the service. We order them usually a month's supply in the blister pack. So if they say they haven't got medication, not us.
I'm talking about the ones that get released straight from the courts and things, and they've come
Yes.
without any.
They should, but saying that, another thing is maybe we can say I can get the message back, keep the meds for maybe a week or two, as long as you guys contact us, and then we can send it through. Because sometimes when they release, we tend to discard the meds, send it back to pharmacy. That's the only thing. Yeah, but then if that works, I'm sure there's something we can do.
I suppose just following on from what you said, that it's been my experiences, and I'm so lucky to have Julie in my area, who's just absolutely wonderful, is if I have a list of patients, say 20 that I don't have a GP for, I'll email Julie and a lot come back that they are in jail. So when they're actually leaving jail, we don't have a GP to follow up with. That's, I think, how people get lost in transit as well.
Certainly, that's Bridget's Auckland remand prison. So all the patients Bridget Fair sees, almost all of them on remand. It's a huge problem. Even though we're getting treatment, it's not a year of interferon, it's 8 to 12 weeks, that people are discharged and they often leave Auckland and don't engage with primary care. Is there a solution from the prison nurses where you could potentially link people so that they see somebody who could supervise their treatment?
This is my proposal, community nurse.
The problem with Hip B, it's good because we've got the Hip Foundation that I always link into, because I'm actually the Hip B nurse in my prison. So they also email me saying, is this person in your prison, etc. With Hip C, unfortunately, because I've been informed that you don't have the contract anymore, it goes out to the community. So if they don't actually have a GP, we can't follow up once they leave, unless they give us an address. Like I said, we normally get all 3 months of Vicera. We give it directly to them when they come back to us. We give them all 3 packs and they take it with them, all the 3 month supply with them to wherever they're going to. Unfortunately, we can't do any more than that because they've left our service. Yeah. If we know that they're going to a CADS program or a specific location to do treatment, then we send everything with them to that treatment place. Their drug chart, medication that they've got, it all goes with them to that place.
So do you find that your engagement with the Hep B relationship with Hip B Foundation is more successful?
Yes, Hip B is a lot more successful because we have that connection. You guys got the contract. With Hip C, like I said, once they leave, they're gone. We don't know until they come back where they've been. And in our population, being remand, a lot of our people do come back within a couple of weeks.
I mean, this is something for the project leads in each area. So, I mean, I don't have a prison in my DHB, but the Joe and the equivalents around the country, I would hope that the project leads and senior hepatitis nurses in each region make contact with their prison colleagues. I don't have a prison in my area.
So in Christchurch, anybody who's been released comes to the Hepatitis C community clinic. We have an arrangement with the prison. So there's a central pharmacy that actually sends all the Ribavirin and Vicaripac out to the prison. Then that's organised that we transfer whatever is over, either from the pharmacy or from the prison, to authorised Vicaripac pharmacy that is close to the person who's been released, and they will come through us. Sometimes they've been prescribed by secondary care.
Jenny, what happens to patients who go to the West Coast, who go to Nelson? 95% of our patients disappear from the ADHB area. Well, what do you do? Do you still follow
That's
them?
very much up to the person, because we have got quite a good GP in Greymouth now who's picking up a lot of the patients that are being released. But what they have, how they do that is really, I mean, even coming to us, they still sometimes just don't turn up. So, but at least they've got some fallback.
Probation usually know where they are, whether they've just been released straight from court, so you can track them through there.
But not everybody get released under probation though.
No, not everybody, but
Yeah.
they usually know caseworkers, they know where they are. I know there's still some that think we're Oh, thank you. We're working with probation in Hamilton. We're just going to start with a pilot. So we're starting to go through the management and looking at, can we actually do point of care testing with people on home detention and work with the probation in the community. They've got quite a big hub there. And we're actually considering running our Hep C clinic out of probation as well, because I don't know much about prisoners, but I'm making an assumption it may be unreasonable, but they may reoffend. And the court is just down the road from where I work, and we were just looking at a way like we're going to do an education to the staff first of all to highlight what we're doing, and we have presented to the Department of Corrections in the region, but we need to up the ante. Working quite closely with Spring Hill, but need to, clinics have been one in Waikeria, but we need to get our connection and communication much better. But I think running this pilot in probation, we're going to learn a lot from that, and we might pick some of those who are lost to release to follow up the meds. And so it'll be interesting to see.
So Joe, can that be a requirement for probation with somebody who's starting? You can't make them stop.
No. Make a commitment. Yeah, I mean, it's pretty cool. We're getting some stories like up in Spring Hill. There's 3 on treatment at the moment. And it's handy knowing the GPs, because he said, well, they're captured, As long as they're there, like, you're thinking the 50 days is a bit tricky. We need them there for a bit longer, really. So perhaps we could look at extending their stay rather than release them early. But I think the closer that we work together, and when we talk to probation staff, they were pretty excited about doing this, because the stigma that Tony mentioned, the offenders, they prepare food at probation thing, and they were being ostracised and told to wear gloves and all that. So it was quite fascinating to reduce that. So we're going to educate the staff, the correction staff, then we're going to put on an education session with Nancy to the offenders, because they do have education time or something. We're still trying to pan it all out and then do point of care and take the clinic there. So we'll use it as a pilot.
Yeah, sounds great.
Lastly for this morning, I would like to welcome back to the stand Alex Lampton-Smith, who you've already become very familiar with. Alex completed her advanced training in gastroenterology in 2014. This included a year and a half in the New Zealand liver transplant unit. And Alex completed a Master's in Medical Science focusing on palliative care in end-stage liver disease. Subsequent to completion of her training, she spent a year at the as a hepatology fellow at the Princess Alexandra Hospital, the home of the Queensland Liver Transplant Unit. And 2 years ago, she returned permanently to New Zealand and is now a gastroenterologist and hepatologist at the Bay of Plenty District Health Board, as well as being a clinical director of the Hepatitis Foundation. And I must say, a stimulating and delightful colleague, and now a mother too. Welcome, Alex.
Thanks. Right, so hepatitis C in the hospital setting. So this goes against everything that we want to address in this forum. We want to promote the fact that hepatitis C can be and should be a community-based treatment, but there are a proportion of people who need to be treated in the hospital setting. This has been, and I've sort of built this talk over this 2 days as well as before coming to this session, so there's some things that we don't need to cover in detail, but I think this was covered this morning by Professor Gain quite well. We know what the main risk factors are. The peak age of infection is people who were perhaps at university or experimenting with life as a 20-year-old back in the 70s and 80s who may now not overtly have the appearances of a stereotypical drug user, so that we need to move beyond the stereotypes of what a drug user might look like. And it's also a smaller proportion of people in New Zealand, but again, anyone who's travelled through the Middle East or Southeast Asia or endemic countries and have had medical therapy in those countries are at risk. And we've talked about those numbers. So countries to think about in your healthcare practice. So for many people coming from other countries, they haven't got it because they've been an injecting drug user. They've got it because they've had contaminated needles in their healthcare environment, or because it's endemic in those countries. So when you're thinking about hepatitis C in people who have moved to New Zealand, it's definitely not the stereotypical drug user. So the countries to think about, as Ed mentioned this morning, China, Pakistan, Egypt in particular, Russian. And so if you are coming across refugees or immigrants to New Zealand, please consider Hep C testing. So the cofactors for progression in someone's liver disease: male gender, comorbidities that are also going to stress the liver, including alcohol, and fatty liver disease is put more together and they have faster progression, and also co-infection with the other big viral infections, HIV and Hep C. They do worse with their liver disease when they carry more than one virus. A rare, well, it's not that rare, but a genetic condition called hemochromatosis, which is common in the Celtic origin population of people who have iron overload and marijuana use. So in New Zealand, we know just over half have got genotype 1, but genotype 3 is increasing. And we talk about this word genotype, we throw it around quite a lot. It's the different strains of the virus. So it's all Hep C. Just for example, like you've got your kiwis, but you've got brown spotted kiwis, you've got great kiwis, you've got North Island kiwis, South Island kiwis. So they're the same virus, but it's different strains, and it has particularly historically affected how different treatments are effective against different strains of virus. So that's just the background on the genotypes. So in the past, it's been a very specialist-based condition. It was diagnosed in the community and referred straight in. Very complex treatment regimens that required intensive clinic review. Even before starting treatment, they needed to be seen by psychiatry, by dental assessments, seen by the doctor, seen by the nurse. Okay, we're ready to go. Yep, we'll go now. And then they start treatment, which was very, very intensive. So consequently, very small numbers treated any one time because not many people wanted it, and because the intensity of the treatment meant that our nurses could only be monitoring a few people on treatment at a time. And then even after you got them through treatment, very low cure rates. We're in this new era of the direct-acting antivirals, or DAAs, as we all call for short, and that slide has been covered. We've talked about this, that there are some challenges with it, but I think once you've done one or two prescribing of it, I think you can get your patter going quicker. So yes, GPs and nurse prescribers can see it as a bit of a barrier, but I think once you've done one or two, or you've linked in with one of the hospital nurses just to help step you through, or a hospital specialist, then you can get into the rhythm of doing the Viekira Pak prescribing, and it absolutely can be done. And yet, quetiapine, Seroquel is a particular one there, as well as some statins. This has also been touched on. We currently have a significant inequality. So if you're winning the genotype lottery at the moment and carrying genotype 1, you have access to high quality treatments. If you carry genotypes 2 to 6, there is nothing funded in New Zealand. So there is an inequity, really. And so that's why we are politely putting pressure on Pharmac and government bodies to say, well, hang on a second, you've got people here who really should be able to access treatment. Tony's alluded to the Buyers Club. Many of our patients have taken up the option of self-importation of medications from overseas. It's sort of quite an unusual sort of concept to think you're going to get a prescription and get drugs from overseas, but it can be done. There's steps to work through, and most of the liver specialists in the country and a number of the GPs have supported people doing this. It's about $2,000 for a course of treatment. But we're all hopeful that around the corner we're going to hear about pan-genotype drugs being available. So pre-treatment staging, this has been touched on a little bit. Really the key reason why is to differentiate between who's cirrhotic and who's not. That's it. That's the key differentiating thing, because once a person has cirrhosis, they remain at risk of the complications of liver disease even after they've been cured. So that's why we really still have that in all the guidelines, that we need some degree of staging prior to commencing treatment. So hopefully in most areas it's FibroScan, and we've talked about the access issues. The APRI score that Professor Gain alluded to requires just the AST and the platelets. You spit the numbers in and they spit out a number, and you can interpret that and say, what's the chance of this person having cirrhosis? If it's a low score, crack on and treat. If it's a high score, they need to be further assessed by specialists. It's who could be discharged following treatment. And the risk of liver failure and liver cancer for people who are cirrhotic does reduce after they've been cured, but it doesn't go back to zero. So we talked a lot yesterday about the logistics of FibroScan, what's involved when the nurses run their clinics, and the test and how it's performed. Very easy test to do in most people, but I just want to touch on the result that we get. Put the wrong slide in. So what is up here, which I've cut off, so when we do a biopsy, we get a METAVIR staging, and it tells us the degree of scar tissue present in the liver. When FibroScans were first developed back in the early 2000s in France, they did thousands and thousands of people where they had a liver biopsy and a FibroScan, and they were the validation studies. And from that, we were able to say, or the French were able to say, that if your FibroScan score is less than 12, you're going to be somewhere in this degree of fibrosis. So we use F0, F1, F2, F3, up to F4. And so very clearly we can show that a liver biopsy that shows cirrhosis is by and large pretty clearly going to have a FibroScan score of 12. So that was done in the validation studies where everyone had a paired FibroScan and a paired biopsy. If you get a FibroScan result of 5 or a FibroScan result of 8, it's a little bit less secure to be able to say that a FibroScan score of 5 is definitely F0, no fibrosis whatsoever, and a FibroScan score of 8 is exactly going to be an F2, but it's good enough. But FibroScan is certainly very good at making that distinction between the people that need to be kept in follow-up and the people that don't, by and large. So that's just explaining a little bit more about that FibroScan result. Okay, so first case, 60-year-old gentleman. Was living in Australia, and he presented over there in 2004 with decompensated liver disease and had the clinical problems associated with that. He also had alcohol as a cofactor for his disease, and he became abstinent at that time. He was also found to have Hep C. So he was treated after his liver disease had settled down, and he was successfully cured from his hepatitis C way back in 2004. Under the service that he was in over there, he was getting the regular gastroscopies because he'd had a varicose bleed, which was one of the things that Frank was talking about yesterday. He'd had this torrential bleeding from his varices. He had repeated surveillance gastroscopies over the subsequent years, and he moved to New Zealand. I met him in 2016, and we did a baseline gastroscopy, and it had completely normalised. His esophagus was normal, which showed that 12 years after eradicating the virus and becoming abstinent from alcohol, his liver had healed. But the first ultrasound I did on him as part of his ongoing liver cancer surveillance showed a liver lesion. He was worked up and he was subsequently found to have a liver cancer. He was able to go forward for surgical resection, which in his situation was with the aim of being curative, because his liver disease had settled down because he'd had 12 years of letting his liver recover. So the curing of the virus and the abstinence from alcohol, his liver had improved. He was no longer in liver failure, but that risk factor for cancer was still present because of the cirrhosis, and so that just really reinforces the fact that these people must stay in long-term follow-up even after they've been cured of the virus. This is people with cirrhosis at the time that they embark on treatment. So treatment now in a person who is in full-blown liver failure, this is definitely something that needs to happen in the hospital setting. For this we have Harvoni, which is a combination of sofosbuvir and ledipasvir, and it is funded for people with stage B and C liver failure, and I'll go on to those stages in a little bit more detail in a moment. And it's for all genotypes, so Harvoni is pan-genotypic, and a hospital specialist applies to the Pharmac committee for that, and it's 1 tablet once a day, usually with ribavirin, and close monitoring just to make sure, because the person is sick, because they've got advanced liver disease and they are very fragile patients, so they do need close nurse monitoring. So this is a further case that my colleagues will probably recognise. So 42-year-old female and alcohol and hepatitis C associated cirrhosis, and she also had some traits of an eating disorder. So in February 2016 she was admitted with evidence of decompensated liver disease, ascites, and this was in the context of some social stresses and an alcohol binge. Gastro was consulted on the ward at that time, and all the appropriate management strategies for her decompensated cirrhosis were put in place, and we gave her very clear messages about the need for abstinence or the likelihood that she would deteriorate and die in short order. So she was seen in clinic a couple of months later, and she was improved clinically, and she appeared to be maintaining that abstinence. And then a couple of months later again she represented and was admitted, again with ascites and biochemical evidence of hepatic decompensation. And on speaking to her, this was in conjunction with a further alcohol relapse. So it's the cofactors that can really push someone along. Now, this is where it kind of gets interesting. So because she was so sick, she at that stage did have advanced liver disease, Child-Pugh C decompensation, and so therefore qualified for Harvoni. At that stage in 2016, you had to have Child-Pugh C, so very advanced liver disease. And it's something that a lot of us noticed is that, yeah, it's the people that were drinking with their Hep C that were qualifying for the Harvoni. But anyway, that has now been extended, and now people with Child-Pugh B and C also get access to Harvoni. So that was just an interesting point that a few of us noticed. So we got her on treatment, and she did require quite intensive nurse monitoring, as much for the social situation and the alcohol abstinence as it was for the actual treatment and any side effects associated with the treatment. And obviously for her liver disease, we needed involvement of the dietitians. Malnutrition, as Frank discussed yesterday, is a massive impact on people with decompensated cirrhosis. And it's actually the most important treatment that we can put in place for someone's liver disease is nutrition. We don't have a tablet that will fix someone's decompensated liver, aside from treating the virus. The most important treatment we can do is sort out their nutrition. So that was vitally important. And we linked her in with addiction services, worked with her family, her grown-up, her adult daughter came to the clinic appointments. And we got her through treatment, and she achieved cure, sustained virological response, or SVR. And she has managed to be abstinent, I think, pretty well mostly. And we've seen her in clinic subsequently, and she's very grateful, and she's engaged with the ongoing therapeutic relationship with us. But yes, so alcohol is a cofactor. It's a big factor in someone presenting with a relapse. So another case, again, not long after I'd started in Tauranga, a gentleman who'd previously had interferon therapy in the community sometime prior, and he had failed that treatment, and he now had decompensated disease and was presenting with large volume ascites requiring regular paracenteses, which is where we very easily stick a little drain in the side here and can drain off anything between 5 and 14 litres over a 6-hour period. And it incredibly relieves their discomfort, improves their appetite, but it is required repeatedly in someone who's got very advanced liver disease, maybe even fortnightly. This was early 2016, so we didn't have any funded antivirals at that stage, and he went on to access the drugs via the self-importation scheme, and he funded that, and we supported him through that treatment, and he achieved cure. So we thought, well, that's great, but the virus was down and gone, but he still had advanced liver disease. He was still requiring regular paracenteses, ongoing diuretics, ongoing input from the dietitians. And it took another 12 months before his requirement for the paracentesis actually settled. So yes, the virus was cured straight up, but it's that the scarring and the damage and the liver disease took a lot longer to improve. And absolutely certainly, he still has cirrhosis, but we've just brought him back from the brink of being decompensated, overt liver failure to someone who's got cirrhosis, and hopefully it's not giving him too many symptoms. So I just want to spend a little bit more time addressing cirrhosis. So this is a histological picture of a normal liver, lovely architecture, lovely uniform shape. You can see how the plumbing is going to flow through that very nicely down through all those channels. That's what a cirrhotic liver looks like. And it doesn't take a histopathologist to see that the architecture is completely distorted. All of those white bands are fibrous scar tissue, and that such severe distortion means that all of that plumbing that is so important in the liver, blood coming from here going through to there, bile going from there out to there, the plumbing and the architecture of the liver is so distorted that's why even when you cure the virus, the day you cure the virus, it doesn't cure that. You've still got the advanced liver disease. And so you can see why a person's still going to have significant symptoms for months, if not years, after the virus is gone. So again, I touched on a little bit yesterday, the MELD score and the Child-Pugh score. I just want to show you some data about outcomes after SVR, and I just wanted to flesh these out a little bit more. So the MELD score takes into account 3 biochemical components, the bilirubin, the creatinine, and the INR. The lowest possible score that the computer will spit, and this is a complex algorithm, I do it online, it's not an easy one I can do in my head. So the lowest score that the computer will spit out is 8, which means you have fully compensated cirrhosis. You have a scarred liver, but your liver's ability to do its job is entirely still okay. You've got a normal bilirubin, no sign of consequent renal impairment, and normal blood clotting profile. And so an 8 is consistent with the Child-Pugh A cirrhosis on the other scale we use. A score of 15 on the MELD score means that you are probably getting symptoms of liver failure, and 15 is the cutoff where we start thinking about transplant, because they've got such severe disease that their outcomes long term do better with transplant than leaving them alone. So a MELD of 15 is an important number, and that's sort of a transplant consideration. So between 8 and 15 you're going from compensated to decompensated. The scale actually goes up all the way up to 40. I've never seen someone with a MELD of 40, and even a MELD of 18 or 20 or 22. They're incredibly sick and they're in hospital. Someone who's got a MELD above 25, I think, is going to be very lucky to get out of hospital on their own 2 feet. So the main numbers that we look at are sort of 8 to 20. And the Child-Pugh, again, just to sort of help you interpret that easily, the lowest score you can have, so it's a score of 5 to 15. The lowest score you can have is 5. And that means that you have a normal bilirubin, a normal albumin, a normal INR, no ascites, and no hepatic encephalopathy. So you have cirrhosis, but it's also functioning okay. As you start deteriorating, your bilirubin's starting to go up, you're becoming jaundiced, your INR is going up, so you've got that coagulopathy, you've started to get ascites. So as you acquire the clinical complications of liver disease, that's when your score goes up. So that's when we talk about Child-Pugh B and Child-Pugh C. So Child-Pugh C is liver failure, and as Frank alluded to yesterday, the mortality from someone with Child-Pugh C is about 60% at 1 year. So it's a worse prognosis than most cancers. So this is a waterfall plot, and I will just orientate you to this picture because I think it does display a good message. So this is, say, 100 people, and this is a group of people with advanced liver disease who were treated, and what we're looking at here is their change in the MELD score from baseline to follow-up week 4 post-treatment. So it's whether their MELD score changed. So if we just say, for argument's sake, that all these 100 people had a MELD score of 15, so pretty sick, so that's, it's kind of the territory we're in. So say all of these people had a MELD score of 15, 18 of them, after treatment, their MELD score hadn't changed. About 10 of them, they'd dropped their MELD score by 1, so a little bit of improvement. And likewise, further 10 people dropped their MELD score by 2 points. So you can see that the majority of people probably get a 1 to 3, maybe 4 point improvement in their MELD score. So if someone starts with a MELD of 15, pretty decent liver failure, potentially getting considered for transplant, and at the other end of treatment, they come down to maybe a MELD of 13, they've still got liver disease. It's not like we've brought them back to a completely pristine, healthy person. They've still got advanced liver disease, but we've just brought them back from the brink. So I think that's an important thing to realise. A proportion of people had no change, and a proportion of people actually deteriorated, and those are likely the ones that didn't respond to the treatment. Similar data expressed in a different way. This is a child's Q score, and again, it's the coloured bars here is how much they changed from their baseline child's Q score. So if someone had decompensated liver disease with child's Q score of 12, and they got through treatment, and at the end of treatment, 12 weeks later, their child's Q score was 11, then they've improved. And what you can see here is just under half the people do get some improvement measurable at 12 weeks post-therapy. A good chunk have no change, and a small proportion deteriorate. So we do see improvement in people's liver function post-treatment, but it's not miraculous. So what do we hope to see once we've got a person through treatment? In non-cirrhotic individuals, anyone who's been involved with Hep C treatment, you'll be very aware that as soon as the virus has gone down and on DAA medications, this can be within 2 weeks, the person will tell you, they will spring into clinic and go, I feel $1 million. So in non-cirrhotic individuals, that as soon as the virus goes down, they feel it, they feel better, and you can see it in them. It's an amazing experience. In people who have compensated cirrhosis, they also feel better, and you can see them that they're lifted, but they've still got that chronic fatigue that can be associated with cirrhosis. And as I've just explained, the people who have decompensated cirrhosis, they still have liver failure. It's just not quite as bad as what it was. So now that we're trying to move more into community-based assessment and treatment of hepatitis C, how do I see my role in this? And I think a lot of my colleagues around the country are sort of doing this in a similar way, that our role is not necessarily to be one prescribing all the scripts for the DAAs, but it's to support our non-gastroenterology specialist prescribers in the community, be that the good GPs or the drug and alcohol doctors or a prison GP or anything like that. So I think our role is to really be overtly supportive, be absolutely building those bridges and making connections. Sometimes we'll get referrals into secondary care saying, can you please treat my person with Hep C? You can just tell that perhaps they feel a bit out of depth, and what we'll do in those situations is do a chart review and dictate a letter back to the GP, very clearly summarising that person's background and what we can get during a chart review electronically, and effectively spoon feed the patient and the GP, say, look, this is the summary of this person's Hep C. I can see they've had a fibroscan, these are their blood tests, I'm not aware of any other complications. I would recommend that you do this, this and this. This is the monitoring that you do or don't need. Please, have a go at doing this in the community, and we can support that way. And I think that has helped some GPs then get that very prescriptive letter back to be able to go on and treat. And I think, the experienced hospital-based nurses will speak very clearly to these next 2 points. Historically, they were all very busy doing interferon-based clinics, and I think it's the nurses themselves and their managers and the specialists that they work with. We need to look at changing the scope of practice of the DHB employed nurse specialists in this field, and really turning them into sort of roving supporting staff in some way, shape or form. And I think that's, doing things differently, looking at, okay, so they're employed by the DHB, but how can we get the PHO to link in? So it comes back to sort of, we might be the ones to come up with the ideas, nurses, how can we work with needle exchange, how can we work with Prostitutes Collective or whatever. But then we need to go back to our managers and the PHO managers and say, look, we've got a nurse who's employed here, but can we actually sort of do this, this, this and this? And I think it needs creative thinking, and I think it needs different teams talking to each other. And I think we have a wealth of experience in our hospital-based hepatitis nurses, and it's how can we utilise that. Prescribing sight unseen, agree with everything Tony said there. It feels a bit weird, but I have a very good trust in my therapeutic knowledge of the nursing staff that I work with, and if I have a nurse They come back to me and say, I've met Joe Bloggs, he's got no comorbidities, he's had a FibroScan, I've discussed treatment with him, he's happy, I'm happy. I say, if you're happy, I'll write the script. Happy nurse, happy doctor. I'm sure there's a saying like that. So I think, so it feels weird to be doing prescribing sight unseen, but if you have a good if the doctor has a good relationship with their nurse and trusts that the information they're being told before they write the script or sign the script, then it can be done. And I'm certainly very happy to do that. And I'm sure many of the other doctors are doing that around the country, doing prescribing sight unseen with their specialist nurses. Yep. And you know, we can be clinical champions in our region. And ideally, you know, the elimination 2030, you know, getting rid of Hep C, a hepatologist is not. I'm not a key figure in this picture, and I shouldn't be. This is public health, this is prisons, so I shouldn't even be here. And so in the next 10 years, I want to see people from other fields coming in and say, yeah, this is a disease that's in our population, you know, what can we do, what strategies can we come up with? The cascade of care, Ed has touched on as well, and I think what I'd just say is, being able to treat the person. So you've got a bunch of people so you've got 50,000 people in New Zealand who we think have got Hep C. Half of those we think are undiagnosed. So the first thing we need to do is find them, and we've talked about that this morning. Getting the people from having a diagnosis to being confirmed, point of care testing, reflex testing. There's ways that we can work with the labs to bridge that gap and bring people forward in that cascade of care. You've got a patient who's floating around somewhere who's RNA confirmed. Bring the prescribing to them. So in what model of care can we get the prescribing out to the community? And then the actual treatment, you know, writing the script. So once you've got them on treatment, they all get cured because we've got such high cure rates. So the actual drug treatment is not the hard bit. It's all of this beforehand. It's not the pill. It's getting the pill to the patient. We're getting, you know, it's all the infrastructure around it. And this is data from the 2014 pilot that the Foundation did to just show the magnitude, magnitude of the problem. And in that data set is that probably only 10, 15, maybe 20% need to be seen as secondary care. The majority could and should be treated in primary care. So I know that there's lots of barriers to treatment in primary care, but this is coming your way. So I think, so what I would say about treatment in the future, it is a primary care diagnosis and assessment and treatment for the majority of patients. I think this can and should be nurse-led in many contexts. And I love the idea of, I think Tony said it, so there's nurse prescribers, and there's a handful of nurse prescribers in the country, and I encourage anyone who wants to go down that pathway to try, but whether there's a role for and would you say prescribing of just one or two drugs, so you don't have to be a nurse prescriber? That was something I hadn't heard about, so would invite anyone who knows more about that to speak to that. I think that would be really exciting for some of our very experienced nurses to, even if you didn't want to go down the whole nurse prescriber pathway, what can be done in this field. And yes, and the minority to come into secondary care. So this is really, well, I think I've said that. So what we can do in the hospital setting is we've got that multidisciplinary availability for the intensive monitoring and the complex patients. Thank you.
Thank you very much, Alex. I've got one question actually in relation. Or at least not so much a question as a comment about one of your last points, which is that we already have a system, for example, where nurses are working in more peripheral. Nurses working in a more peripheral setting and hospital can actually prescribe drugs according to specific triages that are laid down by the District Health Board. Mm-hmm. And there's no good reason why that couldn't be done for hepatitis C drugs.
Sure. So there are three ways it can happen, and all three ways are being discussed with the chief nurse. We see there's some situations like CADS, Community Alcohol and Drug Services, which see an enormous population, 50,000 people attend CADS. We think that they have a rate of Hep C, probably 5 to 10%. Yet the psychiatrists who run CADS are not interested in prescribing largely. So we're looking CADS as being the perfect environment for nurse prescribing. So you can either have nurse practitioners. I think we've got Jackie Stone, one, and I'm not sure how many others we have
nurse.
in Hep C, who have their nurse practitioner courses in Hep C where they're allowed to prescribe without any doctor input. You can do a nursing practicum, many of you will be aware of. If you have a specialist interest, you can do it's several semesters, and you can apply to be able to prescribe certain in certain fields such as opioid prescribing, although that's stopped. And finally, there's standing orders, which is what we've used for rheumatic fever, I think, for strep sore throat. And if you lay out, the guidelines for prescribing for one indication, then that can be approved. The issue we're going to have, and we think that the pan-genotypic treatment is perfect, it's going to be simple, especially in non-cirrhotic patients, that should be made available for nurse prescribing in places like CADS general practice, where there's a big practice and a practice nurse with an interest. Needle exchange also would be perfect. It's not going to be for everyone, but for that to get past the post, it needs to be put forward by the ministry and approved by the chief nurse. And I think that will take time. But I think it's just a matter of time before we have nurse prescribing for the really simple treatments which are coming. I don't think Vicaripax are the all for it, but the next generation.
It's great to see the Ministry of Health staff taking notes. Excellent.
But it's some way away, I think.
Any other comments or questions?
Just a comment you said before about the secondary-based hepatitis nurses working with the PHOs. I'm from Hawke's Bay, but one of my colleagues in Nelson, Belinda, she's been around forever. And last time I saw her, she's been out of the secondary setting for a wee while, but the PHO there headhunted her, and she works 2 days a week, I think it is, between Blenheim and Nelson amongst the PHOs, and it's so successful.
I've met Belinda at a meeting, and it just sounds like what she's doing down there is fantastic.
It's working really well.
Yeah.
So there is, space for that too.
So it's definitely getting the PHO management excited and interested.
Have you got any other questions or comments?
Alex, I just wanted, for some people that didn't know that I'd asked yesterday, the clinical difference between decomposed and composed.
Compensated and decompensated.
Compensated, decompensated. Sorry.
So the compensated disease is a child's Pew score of 5 or 6. So that's the scoring system that's 5 to 15, and if you've got a child's Pew score of 5 or 6, it means that you have cirrhosis, but that your liver is still doing all the physiological things that it needs to do. So we'll call that compensated. So compensated cirrhosis, and these people are, there's nothing to see. There might be a few particular physical examination findings, but there's nothing to see in the larger sense. They do have risks to their health. Their 10-year mortality is higher than Joe Public. Their 1 and 2 year mortalities are around about 10%. And then as your liver disease gets worse and you acquire features of decompensated liver disease, you've got cirrhosis and it's really not able to anymore do its physiological jobs. You're getting signs and symptoms and blood tests of deranged and liver failure. That's when you start having very serious risks to your health and mortality.
Hepatitis C lead to diabetes, heart disease, and stroke?
The question here is, why does hepatitis C lead to diabetes, heart disease and stroke? There's been a lot of epidemiological study that shows that people who have hepatitis C have higher rates or worse outcomes for other conditions completely separate, and that's including the cardiovascular milieu. And it's because there is an inflammatory process going on in their body, and inflammation of any kind exacerbates the changes that are happening in the blood vessel walls that increases someone's risk of a heart attack or a stroke. So it's the inflammatory process that's happening very quietly, very subtly, but ongoing over many years. For the similar reasons, people with rheumatoid arthritis have higher rates of heart disease and stroke, and HIV and other inflammatory conditions. So it's the inflammatory side effect of the virus.
Anyone else? Okay, well, thank you very much for that, Alex.
And just We do just have a couple of minutes, so we were going to just now put my MC hat back on. We've got Melinda from Asham. She's just excellent. She's coming. So Asham is the Australasian Society for HIV, Sexual Health and Viral Medicine, and they are also a charitable organisation in Australia, and the Hepatitis Foundation have links with them, and we just wanted to broach them here. Thanks for your patience for a couple more minutes before lunch.
Thanks, everyone. Asham has been doing some work in re-establishing and connecting relationships with our colleagues in New Zealand. We've been doing that with HIV specialists and nurses for some time, and really excited to be soon doing some more formal work with the Hepatitis Foundation. So thanks to Kelly and Susan for the invite to come along and learn from you all, which I have learnt a lot already just in the last couple of days, and also just to be able to share with you a bit about Asham and how there's opportunities for us to work a bit closer together. Asham's strategic approach is based on these 7 pillars, and I won't go into those because I know lunch is behind us, but essentially this is what drives our business within the work that we do. A big focus for us is on building capacity of workforce, so that's GPs, nurses, Aboriginal and Torres Strait Islander health workers. We do have a lot of allied health staff also attending our education events, psychologists, social workers, other mental health specialists as well. And that's just an indication of the amount of work that we've done in the last 12 months and numbers of people and where we've delivered our education. Our main office is in Sydney, but I'm based in Brisbane with a small team of colleagues, and I've been freezing since I got here on Wednesday. But we do deliver education throughout the whole of Australia, in capital cities, but also regional and remote areas as well. This is a snapshot of the work that we've done in New Zealand. I actually think it's much more than 11 nurses. I'll have to talk to my colleague about that. But we have had, and this is primarily for HIV. We also do a lot of work in the Asia and Pacific region, and the funding for that work primarily comes from the Department of Foreign Affairs and Trading, the Australian Commonwealth Government. And so you'll see that some of your close neighbours are also our close neighbours, and so it's really important for us to be doing the work. This is primarily in HIV within our partner organisations and neighbours. So there's a specific international team that work in those areas. So along with workforce development policy, we do a number of other different bits and pieces. Education is probably our main area of work, and we do that by face-to-face education. So for nursing education, we have 2-day hepatitis B and hepatitis C courses that are mainly targeting primary healthcare nurses who might be new to hepatitis. And similarly for HIV and sexual health, we have 1- and 2-day face-to-face courses. We also have a range of online learning modules and resources as well that are freely available, and you could go onto the Asham website yourselves and access any of that from here. Obviously it's based on Australian strategies and best practice and clinical guidelines, but I think probably a lot of the information would also be transferable. So I am the clinical nurse lead for the nursing program, and my main role is really to ensure that and advocate for best practice nurse education. We have all of our education written and delivered by nurses, nurse practitioners. We work with really fantastic colleagues, and some of you will recognise a few people down the bottom there. We have, like I said, worked with some of the HIV nurses and specialists here in New Zealand. And along the bottom there are our Australian nursing organisations that we work quite closely with. They're just some example of some of the guidelines and resources that we have available on our website, and like I said, they're freely available. Actually, the HIV management in Australasia guidelines are going to have some. There's a nurses and midwives chapter, and we're talking to some of the HIV nurses here in New Zealand about adding some content to that chapter. The Commonwealth Government has funded ASHM for a couple of quite unique projects. This one was to develop a website as a bit of a one-stop shop for cultural and linguistically diverse groups, and also Aboriginal and Torres Strait Islander Australians, to have resources available in language. So I think there's 13 languages, primarily from Southeast Asia, as that's where the majority of our hepatitis B and C outside of our Australian-born non-Indigenous population sits. And so there's audio and visual language resources, and also in Aboriginal and Torres Strait Islander languages we have hundreds of languages across Australia, but there are some languages that are spoken more than others. The other interesting piece of work that ASHM was funded to do nationally was to develop a range of interventions for different health worker groups around addressing systemic barriers for stigma and discrimination that people with bloodborne viruses do experience accessing healthcare. So I've been really interested to hear the discussions about stigma that have been had over the last couple of days, and I would like to say that we would like to say in Australia that we have been able to reduce stigma and discrimination from our healthcare services, but in actual fact we probably aren't doing a whole heap better than what you guys are doing here, and recognise that. So I'm currently in the process of coordinating the development of an online learning module for nurses that does address stigma and discrimination. We would like to think that we haven't contributed in any way to a negative experience for patients, but sometimes we do, and it might just be the nature of where we're working and the policies and practices of that organisation, those systemic structures, rather than our own attitudes and beliefs. That's due for release, I'd like to say sort of September, October, and again will be freely available on the ASHM online learning management system. So I'll send those details through to Kelly, and she can distribute that information when it's out. It is based on the Australian Nursing Code of Ethics, but also Code of Conduct, and framed within the International Council of Nurses Code of Ethics and Australian standards around standards of practice. But I think it would be equally as transferable to the New Zealand nursing experience. We also have a number of flagship conferences, Viral Hepatitis Conference, which is in Adelaide, the 13th to the 15th of August this year, and really pleased to meet a few of you here who I'll also see in Adelaide, which will be fantastic. And then that's every second year event. And then our HIV and sexual health conferences are annually, although this year we have our HIV conference in Sydney in September, but the sexual health conference is actually in Auckland 1st to 3rd of November. There are some scholarships available as well, so if you're interested, go onto the ASHM website and click through the conference link to find that, and that's the Asia Pacific STI conference this year. And then next year, the both conferences will be combined and back in Australia. And that's it. I have to leave at 2 today to head home, but grab me at lunch if you wanted to chat further, or can get my contact details from Kelly. But thanks again so much for having me. It's been really wonderful to hear everything, and I've learned a lot. Thank you so much.